Yes, sir.
Okay. A warm welcome to all my colleagues. Today, I, Dr. Bharat Joshi, will present before you a presentation on traumatic regions of the lip and the oral cavity, how they appear, and what are its management. The contents I will be covering that include the introduction, clinical appearance of various lesions, discussion, and lastly, conclusion. So let us start from the introduction first. Oral overgrowths, they are frequently encountered by all of us clinicians. They were first described in 1848 by Rogers, who was actually doing a review on alveolar masses. However, the impact is that they affect the aesthetic and functional disabilities. And I can say the trauma or the presence of the chronic irritation can result in variety of regions ranging from mucocele to peripheral giant cell granuloma. So appearance of these lesions, they may be either sessile or pedunculated, and these affect usually the younger and the middle age group and do not have the malignant transformation ability. However, the management of these lesions, it depends upon various factors like site, amount of vascularity, and lastly the progression. Let us start from the mucocele first. Now, what is a mucocele? It is a non-cancerous, slow-growing, bluish or translucent swelling which can appear as a result due to disruption or blockage of the minor salivary gland, which is followed by extravasation and collection of mucins in the connective tissue. Usually, it is caused due to local trauma, but there can be other factors also with unknown etiology. Now, in this clinical picture, you can see the appearance of the mucocele. It usually occurs commonly in the inner aspect of the lower lip, but it can also occur on the buccal mucosa, tongue, and followed by the floor of the mouth. And there is no specific predilection. This is the post-operative peak after the removal of the mucosa. Now, next identity is the fibroma. They are basically slow-growing, asymptomatic, benign tumors of connective tissue region, which occurs most commonly in the buccal mucosa. However, they have female predilection for the occurrence, and upon histological examination, they can be characterized by presence of fibroblast and abundant deposition of collagen fibers. Now, this is a preoperative peak of the fibroma, and this is the postoperative peak after the removal. Coming to the etiology, it results from chronic irritation or lip biting or irritation in the cheek due to ill-fitting dentures. The consistency is firm and nodular, but it can be soft and vascular also. And regarding the etiology, we can say that condition is believed to be arising from the periodontal ligament. However, the color is comparatively lighter as compared to the surrounding tissues because of the reduced vascularity. Now next is the another variant, that is peripheral ossifying fibroma. It is a rare condition which arises due to trauma or chronic irritation from plaque, calculus, or any dental appliance. It usually occurs in the anterior maxilla, but it can occur in the mandible also, and it is typically found with female predilection. Now this is a pre and post operative pic of the peripheral ossifying fibroma occurring lower mandible. Now coming to another case, clinically it appears as a slow-growing, well-defined non-neoplastic enlargement, which can have a sessile or pedunculated base having similar color. It can be slightly reddish in appearance. This is another case with both pre and post-operative pics. Now, upon histological examination, we can say there is proliferation of the fibrous connective tissue. Radiographic evidence can have these calcifications which are scattered in the central area of the lesion, and there can be presence of any superficial erosion, but not in every case. Now, coming to the next identity, that is pyogenic granuloma. It is a non-neoplastic, inflammatory, hyperplastic growth of the connective tissue which results from an exaggerated response like calculus, defective restorations, traumatic injuries, hormonal factors, and there can be presence of predilection in the gingiva, that is 75%. Now this is also another pic which shows the pre and post operative pic of the pyogenic granuloma in the anterior lower mandible. Now coming to the histology, it shows greater proliferation by thick endothelial cells with epithelium ranging from being hyperplastic to even thin and ulcerated. It can have stroma with blood vessels, extravasated RBCs, and lastly the inflammatory cellular infiltrate. Now coming to the lipoma, the appearance of lipoma is a soft, well circumscribed and non-infiltrating growth which can be either solitary or multiple in nature. However, it is a benign tumor of mesenchymal cells, can't denote its appearance, and it has certain syndromes like neurofibromatosis and multiple lipomatosis, including the Proteus syndrome. Now, this is a picture which shows the pre and the post-operative pic of the lipoma after its excision. Coming to the histology, it usually contains the adipocytes. That prevalence is not related to the gender, but it has shown some male predilection with the older age group. Usually, it is found in the cheek, which is followed by the tongue, floor of the mouth, buccal sulcus, vestibule, palate, lip, and lastly the gingiva. Then comes the peripheral giant cell granuloma. It is an inflammatory hyperplastic lesion which probably involves a reactive response in the periosteum, periodontal ligament, and gingiva. It occurs as a reaction to local stimulus or trauma. It has tumor-like growth, and the lesion can be seen only in gingiva or the edentulous alveolar ledge. Now, this is a pre and the post-operative pic which shows the appearance of the peripheral giant granuloma in an edentulous space. The etiology remains the presence of the osteoclast, which are from the physiological resorption of the teeth, that is usually after the extraction. There are no radiographical findings because it is a soft tissue mass, and upon histology there is presence of the multinucleated giant cells, and we can explain it as a non-encapsulated mass of tissue with reticular and fibrillar connective tissue. Now, this is a picture which shows the radiographic appearance, and there is no presence of any kind of this calcification in the tissue. Now coming to its counterpart, that is central giant cell granuloma. It is known as the reparative giant cell granuloma. It is an uncommon benign intraosseous lesion, usually occurs in the jaws with a predilection in the mandible. It is considered as benign hyperplastic reactive lesion which is caused by local irritation, chronic trauma, complicated dental extractions. There can be chances of dental restorations, food infection, and lastly plaque and the calculus. Now, this is a pre and the post-operative pic of the central giant cell granuloma after its excision. The clinical behavior it shows from a slow growing asymptomatic swelling to an aggressive lesion that can have pain, cortical perforation, root resorption, and usually it occurs in patients less than 30 years of age. Now, in this picture, in the OPG, we can see due to the presence of this central giant cell granuloma, there is dislocation of the tooth, which usually results in its extraction. The second picture is of the 1th month recall after the excision of this tissue. I can doubt there can be chances of reoccurrence maybe, but we'll see after the follow-up after 1 year or 2 years. So there can be chances of any recurrence also in this case. Now coming to the discussion, enlargements in the buccal cavity, whether it is of gingiva, lip, buccal mucosa or any other region, they can present as a diagnostic challenge. A correct diagnosis is of paramount importance because different lesions can have different treatment modalities. Differential diagnosis do play an important role in the further treatment planning. Lesions namely lipoma, fibroma, dysparagonic granuloma, or peripheral giant cell granuloma, they do present a significant challenge for the clinician to manage and prevent the recurrence. However, the final diagnosis should be made on the basis of clinical, histopathological, and radiographical findings. Now coming to the lesions, lipoma has typical appearance of a yellow-orange protuberant growth with preference on the buccal mucosa, while hemangioma, it has a preference on the lip and the tongue with bluish red tinge. Most common site for occurrence of pyogenic granuloma is gingiva followed by lip, tongue, palate and buccal mucosa. The lesion present as an exophytic growth with a smooth and shiny surface having numerous hemorrhagic papules, or it may be ulcerated and covered by yellow fibrous membrane, so that can help in differentiating from the other lesions. Now, due to the proliferating blood vessels, differential diagnosis of pyogenic granuloma, it is made from hemangioma by the presence of endothelial cell proliferation, in which there is no acute inflammatory cell infiltrate, which is usually found in the pyogenic granuloma. It can has some cases the bone involvement also with gingival preference, while this peripheral ossifying fibroma may occur on the palate also and is relatively less common. Now the peripheral giant granuloma, it is clearly differentiated from the cherubism by the absence of perivascular cuffing. It is limited to the soft tissues, while central giant granuloma being aggressive in nature involves bone also. The presence of foreign body type giant cells and absence of stromal tumor cells, this differentiates central giant granuloma from giant cell tumor. Now, compared to solid aneurysmal bone cyst, there is absence of large spaces in central giant cell granuloma. Now, there is presence of normal serum calcium, parathyroid hormone, alkaline phosphatase, and phosphorus level, which distinguish central giant cell granuloma from the brown tumor of the hyperparathyroidism. Now, the treatment is basically conservative, which involves curettage alone or along with peripheral ostectomy. As I mentioned, there can be chances of recurrence due to the incomplete removal of the lesion. Now, etiology of mucosal is trauma, while fibroma is associated with chronic irritation. In contrast, a fibroma may have smooth or irregular surface, and most of the lesion appear hard on palpation, either with a sessile or pedunculated base. So, after complete clinical removal of peripheral giant granuloma, there can be chances of recurrence in about 10% of the cases, as mentioned in the literature, and which may cause aesthetic and functional soft tissue defects. The treatment options include the marsupialization, laser ablation, and excision by the scalpel or electrosurgery. However, excision by laser have an advantage of minimal post-operative pain, minimal bleeding, no need of suturing the site, and excellent healing after the 1 week. Now, according to a study by Angel Paulos, there can be chances of recurrence more with the lasers as compared to the electrocautery and scalpel. Now, in the end, I can conclude that the aim of this presentation is to summarize the common irritation and traumatic lesions of the oral cavity. I can say these lesions are commonly encountered and are easy to diagnose and can be easily managed by the elimination of the etiological agents, thereby enhancing the healing of the lesions. However, thorough clinical examination and attention to all possible aspects of causative factors are mandatory for the complete resolution of the legion. These are my references. Thank you so much.